course, which will be taking place on these 3 dates here: 11th of Jan, 1st of Feb, 15th of Feb, and our 4-day courses also taking place in Jan and Feb. So please head over to bitepaces.com if you're interested. As I said, we received very good feedback for our recent courses. I'm hopeful that we'll try and do something even better the next diet. But without further ado, I'm going to hand over to Hijaz, who should hopefully be able to share screen.
Just okay. Can everybody see now? Hopefully. And
all
right. Okay.
All works fine.
Yeah. Okay. Brilliant. So I'm just good. Right. Okay. So just to give you a bit of framework of how we approach neurology cases, because what you want to do in each cases is that you want to be fluid in your examination. How to be fluid in your examination is to have a flow in your examination, is to have a structure in your examination. And when you start to have a structure in your examination, you will start to see that you won't be thinking about what to do next. Instead, you'll be thinking what to find next. What are you expecting next in your examination or in terms of your findings? So starting with upper limb and lower limb examination, you start with observation. And in neurology, observation, I think, is the most important bit of a neurological examination, because you can gather a lot of information just by observing patient. And I stress this very, very much, because essentially, say if you have somebody with Parkinson's disease, you'd get a lot of times you can just observe how the patient is really slow in terms of your spontaneous movement. You can see the tremor without even eliciting it. This tremor is already there when the patient is sitting down. You can see orthotics by the bedside. For example, if somebody with a foot drop, you can already tell, oh, that patient has a brace by their bedside. And you can tell, okay, probably he has a foot drop or a peripheral neuropathy of some sort. So, and then you move on to tone, power, reflex, coordination, sensory examination, and then proceed. So from top to toe, you want to see the patient from top to toe, because even though if the examination says examine the upper limb or examine the lower limb, doesn't mean your eye will just stick on the upper and lower limb, because essentially you see patient as a whole. You see a patient holistically. You want to start with the face, and already you can, by observing the patient top to toe, you can already tell. For example, if somebody has on the face with a facial asymmetry, and then when you start you have a certain degree of suspicion of, okay, what this is likely a hemiparesis. Somebody with the right side of facial droop, you might have a right hemiparesis when I examine his upper limbs. So you can start to expect those things: asymmetry, expression, hypomimia, ptosis, voice. Or when you approach the patient, you'd ask them, sorry, can I get your my name is Dr. This, and can I get your name? Are you in pain? Just hear them out, how they talk. You can start to pick up whether they're dysarthric, hypophonic, dysphasic. And in terms of your upper limb examination, what I do usually is that when I start with the upper limb, just let the patient put their hands over their lap and just see if there's any obvious wasting, fasciculations, and you ask the patient straight right up to do a pronator drift. And that's essentially, it doesn't require you to touch the patient, but already you can start to appreciate there is a pronator drift. And when the patient lifts their arms up, you can actually start to observe things that are more hidden, muscles that are more hidden, like areas of the axilla, areas of the latissimus dorsi. You can start to appreciate, and triceps muscles is where they're quite hidden if the patient just put their arms on their lap. So you can start to also do a bit of observation when they put their arms up to check for pronator drift, resting tremor, bradykinesia, all these things. For specifically for lower limb examination, if they ask you to do a lower limb examination, I start even though you observe the patient by the bedside, the first thing I do after observation is to start to ask the patient to walk right away, because gait gives you a lot of answers actually into what the pathology is. And just before the patient returns to bed, you just ask them, okay, before I sit you down again, can I ask this to stand by the side of the bed, bring your feet together, look forward and close your eyes and just see how the rhombus is. And rhombus can be positive either in cerebellar pathology or patients with sensory ataxia, more so in sensory ataxia. Look to the surroundings, whether they have orthotics, patient with a foot drop, you have crutches or NIV machine, especially in patients with motor neuron disease, any neuromuscular disorders, and tend to have NIV machines. So in terms of your tone, so tone is essentially a resistance in a passive resistance of muscle in a passive movement. So the best way to tell if a tone is normal, provided that you don't have any neurological diagnosis, is to test your tone on your own. You can feel a degree of resistance. If you happen to work in a stroke ward, go to a patient and start to feel how their tone is, especially in acute stroke. They're very hypotonic. They're very flaccid. Essentially, it's like moving a thread or of some sort. It's very, very easy. They don't have any degree of resistance at all. Because so that's hypotonia, and hypertonia essentially is increase in tone, but it's essentially divided into two. So you have hypertonia due to rigidity, which is increased tone throughout the entire range of motion, which essentially points toward extrapyramidal causes such as Parkinsonism. And also you have spasticity, which is hypertonia or increased tone at the beginning of passive movement, and it eases off as you move along. So you see spasticity more in patients with central nervous system pathology. So for example, you see somebody with a stroke who has a fixed flexion for spasticity. Try to overcome that spasticity. You'll find that as you at the beginning of your effort to break off that spasticity, it's really hard to open it up. But as you move along, it gets really easy. And this is why it's called a clasp knife. Essentially, when you try to open a clasp knife, it's really hard at first, but as you open it, as you progress through the entire range of motion, it gets easier over time. Rigidity is like cogwheels. So wherever you go, the rigidity is going to be there. The hypertonia is going to stay throughout the range of motion. It doesn't change as the range of motion changes. So that's essentially rigidity. For lower limb, you check for clonus, essentially. And MRC, always think of, it's not really that you have to, when you're reporting back to the examiner of your findings, you don't really have to tell what the MRC score is. But it's really good to have in your mind what does an MRC standard looks like, because it will tell you if somebody has a unilateral weakness. It's easy to tell, right, this patient has unilateral weakness. But if they have bilateral weakness, then what's your standard to compare? So MRC score is very, very, very important. And then how you describe power as well. It's not just in terms of weakness on its own, but also you need to tell whether which muscle group is weak, whether the easy way is whether this is a proximal muscle weakness or distal muscle weakness, and which action is also affected. So that's very important. Reflexes. So you have 3 reflexes on your upper limbs and 3 reflexes on your lower limb. So I just want to bring you to the idea that if you can't elicit a reflex, if you can't elicit a reflex without a maneuver, you have to ask the patient to do a maneuver. So if it's an upper limb examination, you ask the patient to clench the teeth. If it's a lower limb examination, you ask the patient to clasp the fingers together, and just before you strike their tendons with your tendon hammer, only then you say, okay, you're going to prompt the patient by saying, look, I'm going to ask you to pull your fingers together when I say so. So 1, 2, just before you hit the tendon with your hammer, you say pull, and then they'll pull, and then only then you hit the tendon with your hammer, and that helps to accentuate reflex. And if you can't elicit the reflex if you can't accentuate reflex after you've done the maneuver, then only then you can call that reflex as that part of the reflex as areflexia. If you can accentuate a reflex after a maneuver, you call that hyporeflexia. And if you don't need to do anything, that's normal reflexia. So it's very, very important to make sure you know how to do the maneuvers correctly. So upper limb examination with coordination, you do upper limb and your upper limb examination is finger to nose, and your alternate pronation and supination, and your lower limb exam is your heel to shin test, but you've already tested the coordination based on your gait and Romberg's already. Right, so sensory examination, there are 4 modalities that need to make sure you test them: light touch, pain, vibration, and proprioception. So, and this is essentially an examination framework for your cranial nerve. So you go through all of them. So the hardest bit of your examination is actually your ocular and your ocular examination, because there's a few components that you need to test. So I'm going to give this slide by the end of it, essentially what you need to test for in your PACES examination, and actually in real life as well. So remember when I say framework is very important, and the most important table is this. Is make sure that you remember this table and what the components are. And the reason why I say this is, let's say we'll talk about the first case. So Parkinson's disease, right? So it's almost likely that they're going to ask you to examine the upper limbs. But essentially, as I said, once you have a framework of how to work through your examination, you can start to fill in the blanks based on the components of the examination, rather than having to think what to do next in your examination. So let's start with observation. When you approach a patient, as I said, observe the patient top to toe. The patient is going to have hypomimia. They have lack of expression. And just imagine Joe Biden's face. I always tell people, just imagine Joe Biden's face. That's a Parkinsonian facial expression. And then hypophonia, very soft speech. And again, remember Joe Biden's voice. That's a Parkinsonian voice, very hypophonic. And it gets and the volume gets lower and lower as the person speaks. Resting tremor, you can observe this from afar. Pale rolling tremor and bradykinesia, and they're bradykinesic. Bradykinesia is not just when you elicit, just see how they are generally in terms of their spontaneous movement. If they're trying to reach something, if they're trying to do something, they're quite slow in the way that they do things. So that's bradykinesia. So after you've done that, you do your tone examination. You look for lead pipe rigidity, cogwheel rigidity. So look, a lot of the components in Parkinson's disease is based on observation, and the rest of the examination is to confirm what you saw on your observation. So you look for lead pipe rigidity, cogwheel rigidity. The power tends to be normal, sometimes can be reduced, but it tends to be normal. Reflexes are usually normal. In your coordination, you want to look for any evidence of cerebellar signs, because there are certain Parkinson plus syndrome that can cause that are associated with cerebellar signs. For example, multi-system atrophy. Sensory tends to be normal, and this is where the PROCEED comes in. So once you confirm that this patient has Parkinsonism, you want to ask yourself, is there something more than just idiopathic Parkinsonism, a Parkinson's disease? For example, you look for eye movement, look for nystagmus. If there is nystagmus, you can think of something like MSA, which is associated with cerebellar syndrome. Or if there is a vertical gaze palsy, especially upward gaze palsy, you want to think something like PSP. And you look for gait abnormalities as well. So you can, if you have time, even though it's an upper limb examination, you can by the end of it, you can ask the patient to try and walk. If you don't have time, you won't be marked down on it. But if you do, it just shows how smooth you are, or how competent you are in terms of looking for things in your examination. You can offer to do gait. Look at the nature of the gait: shuffling, narrow base, reduced arm swing, increased tremor. And or somebody with MSA, you'll find that they have a broad base ataxia. So it's useful to do it. So these are even though in medical school, I believe that we're taught to finish our examination to the sensory part of it, but in PACES, it looks your PROCEED gives you an extra degree of mark, because it tells the examiner you know what you're looking for, but you have to be confident in what you're looking for to begin with. So think of those things. All right, I'm just giving a framework here and what to look for in different cases that comes to you in neurology. So yeah, so yeah, so yeah. So this is a really good point, and I forgot to mention this. So tone is something you feel, not something you see. So you have to feel the person's resistance to passive movement to tell. And then this is a pill rolling tremor. So it's movement of thumb. So the thumb looks as if it's moving side to side, adduction and abduction, and also the finger looks, the index finger looks as if they're extension and flexion. So that gives the pill rolling movement, and it's a resting tremor. All right. So this is case 2 is hemiparesis of the again the an upper limb case. So again, as I said, have a framework, and once you start to have your framework, I'm going to repeat this over and over again. When you have a framework, you can start to fill in the blanks as you go on with your examination. So look at the face. If there's any unilateral facial droop, speech, either they're aphasic or dysarthric. There's a flexure posturing of the affected limb, like they have spasticity, and pronator drift on the same limb as well, indicating they have a central nervous system pathology. Tone, they might be spastic, reduced power on the affected limb, and hyperreflexic in somebody who has had a CNS or a central nervous system pathology. They might not be able to perform finger to nose because they're hemiparetic, but if there's ataxia, you think of ataxic hemiparesis, especially in lacunar stroke. They might have reduced sensation on one side, but usually normal proprioception. If you think that this patient likely has a unilateral hemiparesis, has a hemiparesis with upper motor neuron signs, depends on what age group. If it's a young person, you'd think something along the lines of MS, space occupying lesion, or young onset of stroke, which is rare. But if you're presented with an elderly patient, always put stroke as your #1 differential, and then think of something else like space occupying lesion or previous multiple sclerosis, trauma, etc. But the proceed examination is that you want to check for pulse, feel if it's irregularly irregular. If it's irregularly irregular, then then that patient might have a stroke actually as a cause of their hemiparesis. A skull take for carotid, the carotid for Bruy. And even though this is a neurology station, doesn't mean we throw away our stethoscope. So very, very important to do that. If there's a midline sternotomy, auscultate for any hard sounds for murmur, because that patient might have had a valvular surgery or infective endocarditis in the past. That could potentially contribute to stroke, to a stroke that's causing the hemiparesis. So these are clues that you want to look for in your examination in these cases. And then just so that's a fixed flexion of somebody with spasticity due to a CNS on. So this patient has a right spastic hemiparesis on the right side. So the lesion is likely coming from the left hemisphere. Right. So lower limb again is just a repeat of what we said just now. But as I said, in lower limb examination, what you want to do is get the patient on their feet right away before you move down to other elements of your examination. So when after you observe the patient, ask the patient right away to walk, and they'll tell you if they can't walk, but at least you offered it, and then see how they walk. So in their gait, they get circumducting gait, and let's just see how they work. So I want you to see how she's, she had to turn in a semicircular manner of her right leg, her right foot. So that's a circumducting gait. And also the way that she walks, if you see that again, somebody with a spastic hemiparesis on the lower limbs, they have strong plantar flexion, weak dorsiflexion. Their legs are straight because they have a strong quadricep. Their quadricep strength is good, but their gluteal strength is weak. So this is what we call a pyramidal pattern of weakness. But you can find it on your. We can talk about that at some point. But that's a circumducting gait. So they tend to be spastic. They have clonus on the affected limb, reduced power on the affected limb, hyperreflex. They're hyperreflexic. Their plantars are upgoing. They may not be able to test for coordination. And again, the proceed for that is similarly the same. So I just want to show you this. So this is very important. I thought you want to see what an extensor hypertonia is. So remember when so if you think about your examination, if you examine the tone, the first thing you do is you roll the patient's thigh. And actually, a lot of people look at the thigh when in fact what you want to look at is the foot actually. So the foot, if it's flailing too much, it means that the patient is flaccid. The tone is reduced. They have hypotonia on the lower limbs. If the foot is not flailing, and it's in fact if it's too rigid, it means that the patient has hypertonia. And the other bit that after rolling, if you think about your examination again, after rolling the thighs, you try to bring up their knees in an explosive manner, as if you're trying to throw them up in the air. A lot of people, a lot of candidate that I saw, they try to look at the knee. I don't know what they're looking at the knee, but essentially what we should be looking for is the movement of the heel on the bed itself. So in a normal patient, your heel should slide on your bed, but in somebody with hypertonia, they jump off like this. So have a look at this again. So have a look at there. So look, it's not sticking on the bed. Somebody with if their heel is not sticking on the bed, it means that they're hypertonic. All right. So yeah, it should stay on the bed. But that heel, that right heel, sorry, that left heel is not staying on the bed. It means that that patient has a left sided left lower limb spasticity. Right. So case 4, this is common as well to come up in PACES, peripheral neuropathy, and this is not just applicable to Charcot-Marie-Tooth, but there are certain features that I'll talk about in that's pointing towards Charcot-Marie-Tooth. In peripheral neuropathy, if you think about what we've learned in medical school, lower motor neuron signs, a few of the lower motor neuron signs, one of them is muscle wasting. So in peripheral neuropathy, especially in Charcot-Marie-Tooth, they get length-dependent peripheral neuropathy. So they have wasting of distal muscles and preservation of proximal muscles. So they have this inverted champagne appearance for these patients. They have high arch foot. If you look at this foot, if you put your hands down here, you'll see there's a tunnel between your hand and the sole of their foot. They get clawing of the toes, which essentially is happening there. So as I said, top to toe. Then if they ask you to look at to examine the lower limb, don't just examine the lower limb. Have a quick glance to their upper limbs. They have distal muscle wasting as well. And as I said, lower limb examination, get the patient to walk early on in your examination. They have high steppage gait and broad-based, and there is broad-based because they have sensory ataxia. So let's just see that. So his high steppage, look at how high he brought his feet up during examination. And number 2, look at how broad the base, his base is. His legs are pointing away too much from what a normal person would have done. So that's a high steppage, broad base gait, and that tends to happen in patients with sensory ataxia or patients with peripheral neuropathy affecting their proprioception. So rhombox would tend to be positive and look for crutches as well. And again, they tend to be flaccid because it's a lower motor neuron finding. They have symmetrical distal weakness, especially dorsiflexion, plantar flexion, and big toe extension. They have absent ankle jerks, plantars are downgoing or absent, and they have predominantly reduced vibration or proprioception in Charcot-Marie-Tooth, but they also have reduced pinprick and light touch. And an extra point, if you do this, is to palpate the popliteal nerve. They tend to be palpable. They have large nerves, which is quite quite a useful sign in Charcot-Marie-Tooth. Another cause for enlarged nerve is amyloidosis, but I don't think that will come up in your examination. It's pretty hard to diagnose. Right. So again, Charcot-Marie-Tooth, as I said, have a glimpse to their upper limbs. They have guttering of their distal muscles. Look at how obvious that tendon is. Just look at your hands now. How compared to the depth of that of between the two tendons is much appreciable in these patients as compared to a normal population. So yeah, look at the first interossei as well. It's pretty obvious. And look for clawing of their hands, like clawing of the toes, similarly to that. And you can try to palpate the ulnar nerve. Actually, you can palpate your ulnar nerve any day because it's quite obvious. But they have, in somebody with Charcot-Marie-Tooth, it's easier to palpate. It's just posterior to the medial epicondyle. So just try to palpate that as best as you can. So the next case is motor neuron disease, and as I said again, I'll tell you again that always have your framework because you can just fill in the blanks as you go around. So upper motor. So always, this is a good formula that I always think that if you have a mix of upper motor and lower motor neuron signs with no sensory deficit, always think motor neuron disease. And you can, they tend to have wasting of muscles, fasciculations. The speech quality is, as I said, it's a top to toe observation. Listen to their speech. They may have dysarthria, dysphonia, and look at the bedside. They probably have NIV or orthotics. The tone can either be flaccid or spastic. Power tends to be weak. They tend to be hyperreflexic, but it's very important for them not. So MND patients must not have any sensory alteration. They do not have any finding in terms of in the sensory neurological exam, because if they have findings if they have sensory deficit, it cannot be motor neuron disease. So this is somebody with ALS. So this is an important point. Fasciculations can be really, really subtle, and you need to take time to observe it. And that's you take time to observe it. Always try to look for it. Another bit is this is what we call spreading of reflex. So he's trying to tap the brachioradialis tendon, which is supposed to cause a degree of wrist, only a small degree of wrist supination. But look at what happens as well. He gets bicep flexion as well. So that's a spreading of reflex. That's a sign of hyperreflexia essentially. And also there's some fasciculations again. So those are really good signs to appreciate. This is on the lower lower limb exam, but again, as I said, fasciculations can be really, really subtle, and you really need to expose the patient in order to appreciate this. So good exposure is key to finding, and good exposure and giving time are keys towards finding fasciculations effectively. So as I said again, a mix of upper motor and lower motor neuron signs in the absence of any sensory deficit, think MND until proven otherwise. Right. So motor neuron disease is anywhere from the frontal lobe, from the motor, anywhere with in the CNS, from the CNS down to your peripheral nerve, affecting your motor nerves and also your neuromuscular junction up to your muscles. It can certainly affect your cranial nerve. You can as I said, there's no sensory changes. Another hallmark of motor neuron disease is that it doesn't affect. There is a sparing of ocular muscles in MND for some reason. But if you look at their jaw jerk, which I'll show you after this, they tend to be brisk. They have they may have facial muscle weakness, which can be either upper motor or lower motor. upper motor means sparing of the forehead, lower motor means no sparing of the forehead, and they have to, and they can either have bulbar or pseudobulbar palsy. So bulbar is bulbar is a lower motor neuron abnormality, whether pseudobulbar is an upper motor neuron abnormality. So we'll observe how the voice goes, but bulbar tends to be nasal quality, pseudobulbar tends to be a hot potato voice, and you can look for palatal paralysis. Always test the trapezius and sternocleidomastoid. They can have wasting and fasciculations, and observe the tongue as well. So this is a tongue fasciculation. So just look at that. So it's not just fasciculation, it's also wasting actually. So there's a lot of tongue wasting. Just look at your tongue and compare yours to this person's tongue. You'll appreciate the degree of atrophy that this patient has. And this is somebody with a pseudobulbar. So look at the tongue, it's very spastic. It's hard for him to protrude the tongue and move the tongue because it's really spastic. And try to listen to the voice. Yeah, as if he's eaten a hot food, and it's burning in his mouth. So that's a pseudobulbar speech. So look at the jaw reflex. You can see that it's positive there. So usually you don't get anything, but if it's present, it's brisk. Yeah, so look at the tongue again and have a look at the back of Okay, all right. So myasthenia gravis is a common thing in examination. So the hallmark of myasthenia gravis is fatigability. All right. So and most of the signs are within the eye movement, and also they are from cranial of 9 to below. So ptosis, this is the hallmark of myasthenia. It must be fatigable, and they have complex. They may have complex ophthalmoplegia, weakness of jaw opening, and they can have facial muscle weakness, bulbar. They can have dysphonia, dysarthria, bulbar quality, so nasal quality speech. They have weak trapezius and wasting. And also, if you suspect somebody has myasthenia gravis, always test the neck flexion and extension. And to add, once you have a suspicion that somebody might have myasthenia, you want to also add a few things on your examination. Test for the proximal muscles. Ask them to do like a chicken wing exercise for about 20 times. And after 20 times, so you test their power before you do the exercise. Ask them to do the exercise and test that again after the exercise. You'll find that the muscle gets weaker after that. Percuss the entire anterior chest. If it's dull, you want to think about thymoma. You want to look for Cushing-like features, especially if they're on steroids, and look for anterior chest scar. They might have had a thymectomy. Well, thymectomy now can be minimally invasive, so you might not be able to appreciate the scars at all. So these are eye signs. So if you look at the eyes, there's ptosis on the left side, and as the person looks up for a long time, it gets worse. I wouldn't bother that too much. It's another sign of myasthenic eye movement. So look, ptosis sets in because it's fatigable, right? So that's the hallmark. This is a curtain sign. You don't have to do it, but what it essentially is that if you elevate one eyelid, the contralateral eyelid will become even droopier. And similarly, if you do on the other side, the contralateral side will become even more droopy, and that's what we call a curtain sign. But again, it's not that you have to show it. It doesn't add anything, but it doesn't add anything if you do it. But because once you've established, you know what to look for the rest of the examination. Right. Unilateral foot drop. Foot drop is also common in your PACES exam. So always look for muscle wasting at the anterolateral compartment of the calf. Gait, look for unilateral high steppage gait. One caveat that I would say is that the reason why you want to look for gait as well is not just high steppage gait, but if somebody has a foot drop and also has a circumducting gait, then that foot drop is unlikely to be due to L5 or common peroneal nerve palsy. It's likely to come from the cord or from the brain itself. So always look for circumducting gait, but that's just an extra point, all right? But so most important, look for high steppage gait, flaccid on affected ankle. So so the question now usually in PACES is that you want to differentiate between L5 palsy, radiculopathy versus common peroneal nerve palsy. So if you have a weak hip abduction, then it's likely L5. If you have if ankle inversion is spared, it's likely common peroneal nerve. If you have a weak dorsiflexion doesn't differentiate, and a weak ankle inversion doesn't differentiate. So ankle inversion is the most useful sign if you want to look for that would differentiate between L5 and common peroneal nerve palsy. Sensory, you might have reduced in light touch at the lateral side of the calf and dorsum of the foot. So once you've established that somebody has a foot drop, what you want to do is you want to do a few other tests. You want to do a straight leg raise test. Basically, you raise the leg up to you want to raise the leg in a straight manner up until they try to get it to a perpendicular position. If it's more than 45 degrees that you manage to bring the leg up without producing any pain, that's a normal straight leg raise test. That's more indicative of somebody with a impingement of an L5. Examine the back for any surgical scar. You don't want to miss this because if somebody had a previous disc herniation surgery like microdiscectomy or laminectomy or whatsoever, you don't want to miss that scar because that's going to give you a bond or clue to what the pathology is likely going to be. Palpate the head of fibula. If there is tenderness, you might want to think of something like common peroneal nerve palsy. Right. How are we doing with time, Shuaib? Do we still have time, or
Yeah.
questions?
Whenever you're kind of comfortable to wrap things up is absolutely fine. So I'll leave it
Okay.
to you.
Sure. I think what I might do is I might just talk a bit about ophthalmology, and I think because and I think the most important part that took me years to learn is how to do a fundoscopy exam. If you have fundoscopy with you, or if you go to the hospital, take a fundoscopy, and what you want to do is set your baseline diopter. So setting your power, basically. What you want to do is you want to if you're wearing glasses, take off your glass, just observe through the aperture of the fundoscope. What you want to do is look to a sign, for example, from a distance, look to the exit sign or whatever. You want to adjust the power until you see the sign clearly, and whatever number is on that diopter, that's your baseline diopter setting. So every time you get a new ophthalmoscope, that will be your power that you will use as your baseline. Say in your exam, say if you're not allowed to bring your ophthalmoscope, but so say for example, my power, my digit on the fundoscope is a 3. So that's my on the red side. So that's my number wherever I go. So, and I will use that as my baseline, and only when I examine patient that I'll change it accordingly as I need to. So always start with that. You start from a distance. You want to start about half a meter away from the patient. And the reason why you do that is because you want to look for the red reflex. Once you've established a red reflex, so a red reflex basically is a reflection of the light from your fundoscope to the back of your eyes, and it'll give you a red color reflex. You can have a look, you can see it from afar. And once you've seen where the red reflex is, just follow the red reflex until you hit the disc. And in a good, usually in your examination, the patient's pupils would have been dilated. So it's likely going to be easy for you to hit the vessel or the disc from a certain distance. Once you hit if you hit a vessel, so it's either you're lucky if you hit the disc directly, but sometimes you may hit a vessel. But don't panic. Once you've seen a vessel, just follow the vessel until you see the disc, because the vessel will always point towards the disc. Wherever you go, just follow the vessel. You won't lose track, because it will always come to the disc at the end. So when you hit the disc, when you look at the disc, you want to look at three things. Number one is color. It's either pale or yellow. Yellow is healthy. Pale means atrophy. You want to look at the cup. This is less important. The cup essentially means you want to look at this is the cup and this is the optic disc. And in somebody with an enlarged cup, it's likely to have glaucoma, but that's not, you won't be asked to do that. And you want to look at the contour, which is basically the disc margin, to see if it's clear or not. And if you have an unclear disc margin, it's likely that patient has has optic disc swelling. And we want to also look at the periphery, because there are a lot of pathologies that might come up in your PACES that they're not directed to the disc, but rather at the periphery of the retina. So always try to look for it. For example, cases of retinitis pigmentosa, or patients with panretinal photocoagulation in patients with diabetic eye disease. They have changes at the periphery. And you want to proceed from there, looking at their visual acuity, pupils, direct, indirect, and RAPD, and an eye movement as well, and move from there on for other miscellaneous diseases. But I'll just drop the slides over here. You can have the slides, and these are certain things. And retinitis pigmentosa is probably going to come up, and there are certain diseases that you should be able to elicit their signs by proceeding through some examination. But I won't go through much. And these are pictures of CRAO, BRAO, CRVO, and CRAO. I won't touch too much on this. I suppose it would be more useful if you go to the PACES course to go through the methodology of how to use your fundoscopy effectively and to be able to appreciate, because pictures at the end of the day are textbook pictures. And the best way to do this is to go to an ophthalmology clinic, which is, if you're working in St. Thomas, they have a neuro-ophthalmology clinic over there. Go to them. They're very nice. Or try your best. If you're doing your admissions, do a fundoscopy fairly quick as part of your examination. That will help you to get used to fundoscopy. I think that fundoscopy skills is mostly about trying to do them over and over again until you really get it. So yeah, I suppose coming to the PACES course would be more helpful to go through this. And I encourage everyone to do that. Right. I think it's better that I'll leave it to this, and if there's any questions, happy to take.
Thanks, Hijaz. Yeah, if anyone has any questions, please do pop them in the chat. I think someone's asked, how do you test for ankle inversion in PACES?
So ankle inversion, you just put your hands at the medial part of the sole and just ask them to bring their foot in, and that's ankle inversion essentially. And the other way around is, if you want to test for ankle eversion, put your hands over on the lateral side of the sole and just ask them to push out, and that's ankle eversion.
Fantastic. And if there's any other questions, please do pop them in the chat. So
popliteal nerve, you have to go back to where your popliteal vessels are. It's at the back of your knee, so usually it's not palpable, but if it is, it's in Charcot-Marie-Tooth. You can find that sometimes. It's at the back of your knees. Yeah.
So this is one that I wanted to ask, because we had a patient on the course, and I think someone was asking, like, how do you differentiate a common peroneal nerve palsy from sorry if you might have covered this, but from an L5 radiculopathy?
Sure.
And it's to do with inversion, eversion, isn't it? From
yeah. So in L5, so if I bring to my slides again, so essentially in patients with L5, yeah. So
You're not sharing
in
your slides, by
somebody,
the way.
so if you have if your ankle inversion is spared, so just imagine where the common peroneal nerve is running, all right? So the common peroneal nerve runs from the head of fibula, it goes down, it divides into deep and superficial peroneal nerve, but it essentially goes down on your lateral side of the foot, lateral side of the leg and the foot. So just imagine that because they're running laterally, in if you have, so it doesn't supply the muscles that affects your ankle inversion. So if you have your ankle inversion, if the ankle inversion is normal, it's likely that it's likely but they have a weak ankle if the ankle inversion is normal but the eversion is weak, then that's likely a common peroneal nerve palsy. If they have weak everywhere, ankle inversion, inversion, eversion, dorsiflexion, that's an L5 essentially.
Fantastic. Adil's asking about fundoscopy and if the eyes would be dilated. To be honest, I think fundoscopy comes up fairly rarely. I imagine they probably would have their eyes dilated, but Hijaz, I don't know if you've got any experience with kind of.
It comes up very rarely because it's not really a pleasant examination for the patients usually, but yeah, they usually dilate the patient's eye usually before the examination, because it would be unfair. Even if they don't dilate, it means that the patient's eye is the pupils are really wide enough for people to just appreciate, and there are people like that. But yeah, usually they are dilated.
Yeah, so question about, I think we will take this final question. It's about most neuron disease and will jaw jerk always be brisk, even in bulbar palsy?
Yes, usually it can. So you can get, so in motor neuron disease, usually you get